I'm really excited to introduce our speaker today, Dr. Jaline Gerardin. She's currently an assistant professor of preventative medicine at Northwestern University and a member of the Institute for Public Health and Medicine and the Center of Global Health. She's also a member of the Northwestern Institute on Complex Systems and the Department of Industrial Engineering and Management Sciences in the McCormick School of Engineering. Her primary work focuses on using statistical models of infectious disease dynamics to understand the combination of interventions needed to eliminate malaria across diverse endemic settings. And she was previously the malaria lead at the Institute for Disease Modeling in Seattle, Washington. So similar to many of us, her research has shifted to having a large focus on understanding COVID-19 dynamics. And many of you may remember her work looking at how mobility networks can explain the unequal spread of disease within a city and how they can also inform reopening strategies. And she also has been supporting the state of Illinois and the Chicago Departments of Public Health in making evidence-based policy for COVID-19 containment, which is what we'll be hearing about from her today. So with that, the floor is yours, Dr. Gerardin.
Thanks, Spencer, and thanks everyone for inviting me. Let me just remember how to share screen here. Let's go. Is it working? I hope it's working.
Yep, we can see it.
Awesome. So I was thinking about just what is most exciting to me right now in the COVID work that I am involved with, and I think it's the new surveillance system that Illinois has been spending the last few months standing up for COVID-19. So I thought I would talk a little bit about this today, and most of the slides are drawn from like an operational update. So apologies if they're like kind of more operational. And I tried to remove kind of most of the nitty gritty, but there's like still some of that there. So definitely feel free to interrupt with questions or comments. Would love to hear like your perspective on this, and I'm super curious if other states are doing anything similar. All right, so kind of a quick overview of what things look like in Illinois. So the state is divided into 11 COVID regions. Sort of, I don't know how familiar people are with Illinois geography. Like I only moved to Chicago 2 years ago, so I learned all this during COVID. So Chicago is region 11 in the Northeast, and then 7 through 10 are kind of the suburbs, and then 1 through 6 are more rural areas. And as we look at kind of the case trajectories, we can see that there's like different dynamics in different regions, and that the rural areas didn't really have much of a first wave, but everyone's kind of been experiencing this second wave, which unlike you guys is more on the decline now for us. Here's the data for deaths by region. And so Illinois like wants to have a kind of like surgical response approach where they have different policies for different regions. So depending on how good or bad different regions are doing, they would enter into more restrictive tiers of mitigation or relaxed tiers of mitigation. So the big challenge then is like trying to figure out like when do we put on these policies or relax these policies. And kind of the data that Illinois is looking at is the data that I think all the states are looking at. Do we consider cases? Do we consider test positivity rate? Do we look at hospitalizations? Do we look at deaths? All of these are like either lagged in the case of deaths or hospitalizations, or kind of prone to shifting underlying changes in detection, such as cases and test positivity rate. And in Illinois, we unfortunately don't collect data on why people are getting their tests. If we had some more information about that, we might be able to interpret the case numbers or the TPR a little bit better, but we don't. So, so looking at those numbers alone is, as I'm sure everyone here knows, like a little bit challenging. So what we've proposed to Illinois was forget trying to set thresholds and decision-making based on things like when we reach 8% test positivity rate, or when our hospital admissions increases 7 out of the last 10 days, which is like, I kid you not, like one of the things that they were kicking around. We said, why don't we do something like use the data that we have. So for example, hospital admissions to calculate an RT, and then make a decision on whether RT is greater or less than 1. I think to us modelers, it seems like a very straightforward concept that you might want to do. And when we're proposing something like this, we're kind of faced with the reality that the data that goes into RT is limited. So if you do something like use hospital admissions, you're by necessity looking a few weeks into the past to assess your RT number. And because hospital admissions aren't usually hopefully huge numbers, you can also get these really wide confidence bands. So what we propose is can we stand up a sentinel surveillance system where we would reduce the lag, we would increase the confidence, and then be able to quantify RT in a more rigorous, less lagged way, and then do this for each of the 11 COVID regions and use that to assess whether things are going well or going poorly. So this was the proposal that Sarah Kobe and I put forward in May. So here, IDPH is Illinois Department of Public Health. So we proposed to IDPH and the governor's office that we stand up a sentinel surveillance system where the sentinel population is mildly symptomatic people seeking testing in outpatient settings who have symptom onset within the last 4 days. So reducing that time since symptom onset will let us reduce that lag in calculations of RT. And our thought was these people are already going to get tested. This is not standing up a new active surveillance system. This is your existing passive surveillance, but can you just use your data streams to kind of segregate out this population and then use the dynamics in this population as a surrogate to assess the dynamics in the wider population. And of course, if we're focusing only on symptomatic people seeking testing, we're not getting an actual estimate of population prevalence of COVID, but we are probably going to get a good assessment of the trend. So that was the goal with looking at this core group. And then we also thought that maybe some supplemental groups might be helpful. So for example, pregnant women presenting for labor and delivery, even as early as May and April, many hospitals in Illinois were already doing pre-procedural testings, probably similar across the nation, including most hospitals in Chicago were testing women presenting for labor and delivery. And we said, this data is already being collected. There was a study from New York City that at the time that said, something like a huge fraction of women presenting for labor and delivery were testing positive. And we thought, well, could this be a nice convenient population for us to track trends, especially since the data was already being collected. And then we also proposed a couple of other groups. So this was again, proposed in May, and around July, we'd had enough conversations with them that stuff started to happen. In July, the labor and delivery data began to get reported to IDPH, and that's when we began monitoring prevalence in women presenting for labor and delivery. In September, so a couple months later, the first outpatient data collection began at one pilot site. There was a huge operational difficulty in setting up the outpatient data collection. Obviously, these people were, already going to get tested, but the huge barrier was the IT and data systems needed to do this. There was the fact that testing happens is provided by a huge diversity of providers in the state. So some tests are sent to the state lab, some tests are sent to private providers, some tests are sent to hospitals. So because there's this big diversity, the data streams are I guess, incredibly complicated. And it was easiest for the state to say well, let's just use the community-based testing sites, that's the CBTS, that we administer. Those samples come to our lab. We have more control over what goes in the questionnaire that patients are presented with. And between kind of July and December, they finally sorted out the IT issues. Apparently adding one question to that questionnaire is not easy from an IT perspective. And that was really, I think, the big barrier. So by October, there were more sites that were brought on board. There was also a meeting with LabCorp, who does, I think, tens of thousands of tests, processes tens of thousands of tests in Illinois every day. The issue with LabCorp and kind of our idea of sentinel surveillance is that LabCorp is currently not asking, you know, anything that would recover the time since symptom onset. And for LabCorp to add a question into their form, this question would not be limited to their Illinois samples, it would be nationwide. So that was another, I think, barrier that would happen with LabCorp. And there's also, you know, more legal agreements around like data transfer and things like that. So that is still in process. The IDPH is actively working on kind of getting that coming through. But by the end of December, we had 70 sites with representation across all 11 COVID regions. So that's pretty exciting that's kind of where things are right now. To give an idea of like the scope of things, I just want to highlight here the sites row in that the community-based testing sites, I think the previous slide was a little bit old, but 70, now, I think now it's 133, again, hitting all 11 COVID regions, but they hit the COVID regions a little bit differently because some regions have more sites that are administered by their local health department, such as Chicago, and fewer sites administered by IDPH itself. So that's another barrier. And then the daily volume for the community-based testing sites that are reporting for sentinel surveillance, we have around 300 to 600 tests every day statewide that are in the sentinel population. And that's just out of statewide, we have about 100K tests happening every day. So it is a huge, huge minority of all the tests. Definitely the vision that Sarah and I had initially was to have all outpatient testing sites enrolled in sentinel surveillance eventually. And I still think that that is perhaps possible, but that's not really where we are right now. In labor and delivery, we were able to get most hospitals to report, but not all hospitals. There were hospitals that didn't want to participate. There were hospitals that said they just didn't have enough tests to give them to people who weren't symptomatic. So the volume there is also a lot lower. So I think so here where it says daily volume is around 120 to 150 tests statewide, that represents, I think, just under half the births that are happening every day in Illinois. In terms of the population that is showing up for these sentinel surveillance program, it's not exactly the same as the general population. I think a couple of things are a little bit concerning here. One, I think, is the age is a little bit younger than the general population. And the other one is that the sentinel population is more white, less Black, and less Latino than the Illinois population at large. And we know in our state, we've definitely had big disparities in COVID burden that is hitting non-white populations disproportionately. And so seeing that the sentinel population is skewing white is not exactly a great sign. So we could easily be missing concerning trends that are happening in the non-white populations. All right, so I'm going to show you some like early data that we have coming from the sentinel surveillance program. And I'm going to be comparing the sentinel data to COVID-like illness or CLI admissions that are reported by IDPH. So everything is going to be at the COVID region level. So here is region 2. Sorry for like the tiny text here. Again, like I like really did a hack job on someone else's slides. But so what we're seeing here in both plots, the CLI admissions is shown in the dark line. And then the yellow lines are data from the sentinel surveillance program. So on the left here is just sentinel cases. So the number of cases by date of symptom onset each day that are collected at the sentinel site. This was the pilot site, so it tended to have, you know, a little bit data that extended all the way back to August. And then on the right side is the test positivity rate for that sentinel population. And I'm showing that one because we can have a nice confidence interval on that, which gives you some qualitative assessment of just how many samples are being collected and what's the confidence on that sentinel trajectory. And so what Phil Arevalo from U Chicago did is that he took the sentinel cases and compared it with the CLI admissions to assess the correlation and the lead time of sentinel cases over CLI admissions. For region 2, we're getting a lead time of around 9 days, which is actually, I think, quite a good amount of lead time if you're, especially if you're in growth phase, to get an early indicator of changing trends. So that's really, this was very exciting for us to see kind of in late December when we first saw these plots. But the case is like a little bit different for different regions. So not all regions even are collecting enough samples that we can make these like plots like reasonably. For example, region 3, you can see prior to early November, like that super, super fat confidence band on the TPR saying that, you know, there's like not so many cases like collected at all. We can't really interpret the trend very well. Even so, it seems like the sentinel cases are leading the CLI admissions by around 6 days or so. The shape is perhaps a little bit different, but we do see the sentinel cases coming up and then declining and then flattening, which is reflected in the CLI around 6 days later. Region 4, again, something, again, similar. We're seeing a lead time of maybe 7 days. And then region 10, we're seeing a lead time of perhaps 3 days, but here the patterns in the sentinel cases and the patterns in the CLI don't look all that similar. We're trying to understand what is going on with region 10. And so like it's a process, but it's really exciting to see that there is some kind of good, promising indicators that that sentinel surveillance could be giving you at least like maybe around a week's lead time on these dynamics, which is very cool. So I'm going to move next into some of the challenges. Sorry. Before that, just a little note about the labor and delivery. So labor and delivery went on for several months, and when we had this fall surge in COVID hospitalizations, we actually found that those patterns were not very well replicated in the labor and delivery population, which was number one, a bit disappointing that this very convenient sample was not going to be a good indicator of trends, but also secondly, kind of encouraging that it seems that pregnant women were able to like really take good, strong action to protect themselves, so that the big surge in COVID that we saw statewide was actually much, much more mild in this population. So, you know, after looking at this, we decided with IDPH that we would discontinue L&D surveillance. At least they were reporting weekly, so definitely not reporting weekly, perhaps reporting monthly, just because it was a reporting burden on the hospitals and it wasn't really giving us the data that we were looking for. Though I do want to note that there was a positive outcome of this surveillance in that that because a lot of the positive tests were found in asymptomatic women, learning this made the hospitals that were previously not doing pre-delivery testing decide that they would start doing pre-delivery testing, just because the prevalence of asymptomatic infection was not zero. So that was a good result. So we'll see what happens kind of in the new year, if that monthly reporting cadence will still kind of continue, if we're still going to continue to track this population, but it's definitely been deprioritized. All right, so moving on to challenges. So the biggest challenge is, of course, the number of samples that are coming from each of the 11 COVID regions. So we can see here, this is what things look like kind of up until last week or so. We see that pilot site that started in late August, and then kind of in early November, more sites added to the program. The volume of testing here, that kind of higher in November, lower in December, is something that we basically see across the state, that that testing hasn't fully recovered to pre-Thanksgiving levels. So we'll see how things go now that the entire holiday season is over. Maybe testing will pick up again. But compared to like the entire population that is showing up at these community-based testing sites for testing, we can see that the sentinel population, so symptomatic people with symptom onset within the last 4 days are the minority of people. And this is different by COVID region. So here I'm showing on the x-axis, this is the fraction of tests that are happening at sentinel sites by region. The yellow is the sentinel population, so mildly symptomatic, symptoms within the last onset within the last 4 days. In purple is symptomatic, but symptom onset longer than 4 days ago, so people who showed up to testing a little bit later. And then in the dark blue color is people who didn't have symptom onset data collected. So looking at this, IDPH went back and revisited the questionnaire, and it turned out that that collecting the symptomatic status was a little bit suboptimal. So people were getting a question, are you symptomatic by CDC definition? And like no one really knew what that was. And then there was like a really long list of symptoms that that someone would read to you, and you would say like, yes, I have that, no, I don't have that, which was taking a lot of time. So that was revamped, I think, in late December. So hopefully that collection will be better. And then the symptom onset, I think that they are also they also decided to, rather than ask for a date, just ask how many days ago did your symptoms start? Because I think that they thought was going to be more straightforward for people to answer, which I agree. That would be more straightforward for me to answer as well. So that's pretty, hopefully we'll see in the new year that those changes will increase the proportion of samples that are sentinel samples amongst the symptomatic population. So overall, this is the number of daily sentinel samples collected by region. We can see that region 2, that's where the pilot site is really doing the best. And in many of the regions, we're talking quite few sentinel samples per day. And this, of course, is leading us to have insufficient samples for making a good and strong RT calculation. So IDPH is actively working to increase testing volume. They're working a few different avenues, including LabCorp, which would be pretty exciting. But in the meantime, our groups are working on the analytics side to to figure out how to translate the sentinel case trends into a stoplight indicator, like red, yellow, green, to assess for each region how it's doing. Just skip that. Another challenge was test turnaround time. Of course, if your test turnaround time is very long, then you are still giving lagged indicators. So to date, only half of the test samples were returned in under 48 hours. This was really not good, but they made a big effort in December. So this is just the December data. And have pushed most of nearly all, actually 90% of the test samples to be under 48 hours. There's a couple of sites that are still returning, giving turnaround times longer than 6 days, which is absolutely abysmal. But IDPH is working to figure out what's going on there. It seems to be certain sites rather than some tests from each site. So hopefully addressing those problems is really going to help on that. So this is kind of where we are now, at least at the late December operational update with this. The state is still really, I think, engaged and excited about sentinel surveillance, which is good. And the state is also really concerned about the issue of the new, more transmissible variants. And so sentinel surveillance is still alive and kicking. Really hopeful that that we can get more enrollment, more samples for each of the regions, so that we can kind of get some more robust numbers there. And with that, I'll just end here, and I'm happy to take any questions.